Now I would like to invite Professor Dr. J.S. Bhalla. Sir is the Senior Consultant, Professor and Academic in charge of DDU New Delhi, and he has 28 years of teaching experience. He would be giving the keynote address on Bleb leak identification and management.
Thank you. Again, I'm thankful to the KSOS for giving me this opportunity. The topic I'm going to cover is identification and management of Bleb leaks. The incidence of post-operative Bleb leak after TRAB ranges from 0 to 56%. It can be both early and late, and the late leakage is about 3 to almost 13%. Early Bleb leak occurs in the early post-op period after glaucoma filtering surgery, and it is usually due to the surgical trauma to the conjunctiva or inadequate conjunctival closure, and it can be avoided by careful and meticulous surgical technique. And the late Bleb leak occurs months to years later, and it is usually following adjunctive use of the antimetabolites. Bleb leaks can be high flow leaks that are CDL positive, or they can be low flow leaks that may present with just Bleb sweating or transconjunctival ooze. And late Bleb leaks are more commonly seen with cystic avascular Blebs compared to the thick walled Blebs. So these are some of the terms that are commonly used in the publications. Leaking Bleb is presence of positive CDL test, that is fluorescein dye being washed away by the aqueous. And sweating Bleb is increase in the fluorescence of the Bleb area with no obvious aqueous streaming on the CDL test. And there is no conjunctival defect in the sweating Bleb, but it had either staining or slow ooze of aqueous with hypotony. Hypotony we label with IOP less than 5 mm mercury on more than 2 occasions, and hypotenuse maculopathy loss of more than 2 or more than 2 lines plus presence of the macular folds. So what are the complications associated with Bleb leak? It can lead to hypotenuse maculopathy, choroidal detachment, shallow or flat anterior chamber, and then corneal anterior segment complication like corneal decompensation, cataract formation. This leads to increased risk. It is a risk factor for Bleb failure, and these Blebs are more prone to blebitis and Bleb-related endophthalmitis. So how can we prevent the wound leaks? One is smaller conjunctival incision in both the fornix and limbus-based conjunctival flaps, prevention of conjunctival tears and buttonholes by minimal tissue handling, and in fornix-based flap, we should do meticulous watertight wound closure. May include Tennant's layer in the closure, and the corneal conjunctival closure is done also, which can prevent the wound leak in fornix-based flap. In limbus-based flap, we should place the conjunctival incision as posteriorly as possible, and we should do careful conjunctival edge protection during mitomycin C use and use of the round body, not non-crushing conjunctival clamp. And what are the treatment options available for Bleb leaks? Medical is in the form of antibiotics, cycloplegics. We can use bandage contact lens, or the Simmons shell can be used. And surgical is by conjunctival resuturing or Bleb repair with conjunctival advancements or conjunctival autograft, depending on the size of the conjunctival defects. So these are some of the surgical procedures. We can either use Tennant's capsule is sutured into the buttonhole as seen on the left first slide, or we can use the 10-0 nylon mattress suture to close this buttonholing, or tear in the conjunctiva at the limbus can be closed by making a small corneal groove, and then we can suture the conjunctiva to this groove. We need to differentiate ischemic Bleb from blebitis. See, blebitis presents with ischemic conjunctiva and surrounding conjunctival and ciliary congestion, most intense around the Bleb edge, whereas when it is associated with purulent discharge, chemosis, and anterior chamber reaction like KPs and hypopion, then it becomes blebitis. So what are the conservative measures? I'll again reinforce. These are antibiotics, cycloplegics, pressure patching, bandage contact lens, collagen shields, glaucoma shell, Simmons shell tamponade. We can use aqueous suppressants, Bleb needle redirection, laser application to the Bleb, autologous blood injection has been done, and also the use of cyanoacrylate tissue glue. Collagen cross-linking has also been used as one of the procedures where it is a non-invasive treatment offering reasonable success rate for filtering bleb leakage, and we may not require invasive surgical bleb revisions. There is also role of oral doxycycline and large diameter bandage contact lens. Oral doxycycline, by inducing inflammation, and anti-metallum MMP can really help in the treatment of bleb leaks. So what are the surgical choices? Surgical choices are these as listed here: conjunctival advancements or conjunctival autologous conjunctival patch grafting, amniotic membrane transplantation, scleral patch graft, corneal patch graft, even the facial autograft has been used, bleb needle redirection, and bleb plication as also is one of the procedures. So choice of surgical repair depends on the size and site. Conjunctival advancement is preferred in presence of small avascular bleb or small anterior leak, which is usually less than 3 millimeter from the limbus, the surrounding healthy and mobile conjunctiva. An autograft is used in the presence of large avascular bleb or a small bleb with surrounding scarred conjunctiva. Excision is done if the bleb wall is ischemic and unhealthy, and then the whole bleb is excised. So indications for bleb repair are bleb dysesthesia, large sweating bleb, or bleb leak or blebitis. So in summary, bleb leak with no hypotony or significant anterior chamber shallowing, we can use bandage contact lens. Bleb leak or leak associated with AC shallowing, choroidals or hypotony, surgical repair of the leak is done. And we can also use aqueous suppressants like oral acetazolamide. Topical steroids are reduced. And if a conservative approach fails to solve the bleb leak, then we may have to use interventional approach like conjunctival enhancement or conjunctival autograft. I'll also take this opportunity to request all of you for supporting my candidature for Joint Secretary AIOS in the coming online election. Thank you everyone for your kind and patient hearing.
Thank you. Thank